Good morning. Thank you for attending the 2020 Behavioral Health Symposium. We are happy to host this event as a virtual conference because we care about your health and safety, but we also understand how important it is to provide relevant and robust continuing education to Louisiana healthcare professionals. For quality purposes, all participants will be muted during the presentation. If you would like to submit a question to the speaker, please use the Q&A feature in the virtual platform. This session is accredited for 1.25 hours for the following: social workers, general credit, licensed professional counselors, peer support specialists, psychologists, nursing contact hours, AMA, PAR, Category 1 credits. Full participation is required to receive credit and will be monitored throughout the session. You will receive an email from Women's Foundation with detailed instructions on how to claim your credits and access your certificates. Additional information is available in the digital event booklet. Frank Campbell has no financial disclosure. None of the members of the symposium's planning committee or any session moderators have any financial disclosures. Our keynote address this morning is entitled, "Do You Really Have a Suicide-Aware Vocabulary?" The keynote speaker is Dr. Campbell, who is the Executive Director Emeritus of the Baton Rouge Crisis Intervention Center, where he serves as a volunteer chair of the National Suicidology Training Center. He is also a volunteer assistant coroner in East Baton Rouge Parish. In addition to his volunteer activities, he is a senior consultant for Campbell and Associates Consulting, where he consults with communities on active postvention efforts and forensic suicidology cases. During his more than 30 years of working with those bereaved by suicide, he introduced his active postvention model in 1997. It is most known as the LOSS Team, Local Outreach to Suicide Survivors. His work with survivors and victims of trauma has been featured in 3 Discovery Channel documentaries, professional journals, and book chapters. He is a past president of the American Association of Suicidology, a recipient of both national and international awards for his contributions. Dr. Campbell is also a veteran and is most proud to have been a consultant and contributor to the TAPS program for military family members who attend the survivor seminars and the national programs for the past decade. To learn more about his work in the field of suicidology, you can visit his website, www.lossteam.com, or the NSTC at www.brcic.org. Dr. Campbell, we would like to acknowledge and thank you for all the work you've done and continue to do for suicide prevention, intervention, and postvention. We thank you for being here today and for your continuous contribution to safer suicide care for the citizens of Louisiana. So without further ado, it is truly my pleasure and honor to introduce the keynote speaker, Dr. Frank Campbell.
Thank you, Brother. I appreciate you serving as moderator as well. I know that it's early in the morning for most of us, and having a vocabulary lesson this early in the morning may take you back to another time in your life when we weren't doing school around the kitchen table. Also, recognize that for many of you, talking about suicide this early in the morning wouldn't be typical. But with the theme of the conference being changing the conversation, I think it's appropriate, and I certainly appreciate the opportunity to come and talk with you about our vocabulary. Because if we're going to change the conversation, part of that is going to be educating people on the terms that we would like them to understand more clearly. I do believe that language matters. I would say that in most cases, these 5 words are better than those 5 words. And quite often, we're able to notice the words that don't fit. But in my experience and working in the mental health field for as long as I have, I would say there's probably some words we ought to let go of, and there's some we ought to take on. And perhaps it's because suicidology isn't a word that just kind of rolls off your tongue. It might be important for us to have a little bit of Latin in the beginning this morning. One of the first things I want to just remind you of in this first slide is that there are no disclosures financially. I'm grateful for the fact that I work as a volunteer now and can generate income for the Crisis Center that now celebrates this year 50 years of service that began at LSU in 1970. It came as a result of multiple students having taken their life in the fall semester of 1969, including our student government president. As a result, students started the first ever student crisis line. And today, those lines are answered by a program called Via Link out of New Orleans. And the Crisis Center has undergone a change. We thought at 50 years it might be a time to update our mission. So a couple of years ago, we founded the National Suicidology Training Center. Now, I asked the board of directors to consider this because in my experience for the last years, about 15 years now, I've been doing forensic suicidology, which just means that you testify as an expert witness in wrongful death suits. And certainly all of us that practice and carry liability insurance do that with the fear that one day we might find ourselves in a lawsuit. A wrongful death lawsuit is one of the most challenging things for your career, to experience or to have to endure. What I would notice as I was asked to read different cases by attorneys is that for the most part, family members and friends had done everything they could for the individual that was being brought for care. In most cases, their fear was strong enough that they brought them to a hospital where they were sure there would be people on the inside of that facility that if they admitted their family member, they would be able to help them stay safe from suicide. As I would read the case notes and the entries in that person's treatment protocol, what I would learn was that although they were admitted to the hospital for danger to risk or danger to self or others, no one ever entered one time where they talked to the patient about suicide. And under testifying and depositions, quite often, when asked, what did you do regarding suicide, the case manager, the treatment provider, the psychiatrist would say, well, we explained to the patient that if they denied thoughts of suicide 3 days in a row, they would be allowed to go home. Now, for those who think that's a treatment approach, let me begin by saying it's not. It's really saying to a person, as long as you tell us you're not having thoughts of suicide, you'll be able to leave this place where you're not getting any treatment for your thoughts of suicide. Now, thoughts don't equate to death, but so many of the individuals, a very low, above a flip of a coin percentage, left the hospital and died by suicide within 24 hours using the very method that on a voluntary admission they described they were thinking of doing. This to me was alarming, and it continued to be going on every time I would read a case. So I came to the board a few years ago and I asked them to consider opening a National Suicidology Training Center here in Baton Rouge at the Crisis Center. And for the last year and a half, that's been a very successful environment. We've had people coming from all over the world to get additional training. One of the requirements of the training for me was that we would never have more than 20 people in a room. We really wanted to be able to drill down on the topic for days at a time so that when people left, they could go back to their own community where they could become the expert or the resource in their community on that particular training field. And so we found that to be a positive environment. We use the metaphor of a lighthouse, that lighthouses need to be in every community pointing towards safe harbor. And that means that safe harbor has to have people there that are familiar with and understand the terminology surrounding treatment of suicide. Suicidology from the Latin just means study of suicide. So here's your Latin class this morning. Anytime you have a word that ends in ology, it means study of. So when people say to me, suicidology, what is that? Well, it's the study of suicide. And I'm going to give you more details about what that study includes. But forensic suicidology, forensic just relates to justice. It's not necessarily about being in a NCIS episode. I know that we have let television possibly falsely make us believe that we can take a photograph of a body and somehow know their DNA and their toxicology at the scene of a death, but that's not true. The reality is, having been to hundreds of scenes, no two are the same. And that's what I know about suicide. So let me begin by saying most of what you probably know at this point about suicide is the opposite is probably true. Suicide is a paradoxical cause of death. It means that opposites will be true throughout your study of that individual or the field of suicide. Now that's helpful to begin with because that allows you to understand why a person might present in an emergency room. And the first person that assesses them says, we need to hospitalize a person. I'm afraid they'll take their life. They're imminent risk. And then they sit there in the room for an hour or so before a second opinion can come in. And the second opinion comes in and leaves the room after their assessment and says, there's no reason to keep this person here. We need to send them home. And in my opinion, both people did an accurate assessment. The problem is they talked to the two sides of suicide. The first person talked to the side that wants to die. And that's why they were sure that this individual might be at risk and needed to be hospitalized, temporarily safe inside the facility. Although people do take their lives inside inpatient settings. The other person was true and accurate in their assessment because they talked to the living side, the side that wants help. The problem we have is that the dying side wants to be understood. And if they're not given that opportunity to talk about why they want to die, talk about why suicide is a solution at this point in time, then they never get that expressed. They never get that information out there. They don't get a chance to move it from their thoughts into actually their vocabulary. And our vocabulary quite often, when we hear ourselves say something, it changes how we think about that word. Let me give you an example. Have you ever noticed that sometimes you use language at a party or a place that you're with other individuals that aren't in the clinical field, and you'll use a term or a reference and they go, oh, what does that mean? And you have an opportunity then to explain to them your knowledge of DSM or whatever language you're speaking at the time. Because we often speak in acronyms, we often use shorthand to explain or talk about a diagnosis. Have you ever noticed that sometimes if you're the social worker in the group and there's a psychologist and a psychiatrist and an LPC there, that people might use terms from their own particular practice that you don't understand? And you may or may not feel comfortable asking them, what do you mean by that? So do you see how vocabulary, even within a mental health environment, could change? And then there's sometimes we say things and we really wish we had not used that slang. Maybe you've been in a work environment where you've heard someone use slang words that are overheard by a patient or a client. Imagine if you've got a family member being reviewed for suicide who's been into this hospital several times in the past, and you hear someone comment, oh, we got a frequent flyer in number 2, and that's where your family member is. These terms are often batted about and used as shorthand to confer information that you assume about an individual because of multiple hospitalizations. But imagine what that might feel like to the family. When I've read those case files and seen this actually used as a term in their record, it says to me that anyone who reads that record afterwards can't undo the bias that that comment makes. It creates an image in your mind that says this is an individual that is chronic and probably doesn't have a positive outcome even with treatment. Because if I ask people what they mean by that, that's commonly what they mean. This person's in and out of the hospital. No matter what we do, they come back every time. It creates a sense of hopelessness in treating that person. But for that family member, it lowers their expectation that anything different or new will be done for their family member this time. So let's say sometimes a word itself is the issue. So suicide is one of those words. It means different things to each person. And depending on how it's used, it can be everything from the brunt of a joke to a very serious and fearful thing. How many times have we heard this word referred to as a taboo word? I've had the opportunity to work in Australia and New Zealand and met both Aboriginal people and Maori people where this is not a word that's used. And I've had to accept that in cultural areas, there's sometimes important for you to know that in certain Aboriginal populations, once a person dies, you never speak their name again. To speak their name is actually a very distressing thing for the family to hear. So you might think saying their name in American culture quite often is a very positive thing. But if you're not aware of whether that individual is okay with that, you may be putting salt in an open wound. Suicide is one of those words where we hear it joked about on television on a regular. It's absolutely a comic relief idea on many sitcoms. We have people use gestures where they point to their head with their finger and pretend to pull the trigger of a gun using their hand. That's called a gesture, by the way. And what we're saying to those family members that have had someone die by suicide is just a joke. I can assure you it's not a joke for that family member, especially that person that came home and found their loved one having taken their life. So suicide is one of those words that is paradoxical. It can come from being something that's sad, scary, and difficult, and very difficult to understand, to something that's joked about. So do you see how this paradoxical reality is there for all of us, regardless of where we come to this word? So if in your life you've not been touched by suicide, if you've not had to deal with this word in a very direct fashion, you won't have the same appreciation for it, perhaps, as others who have. So let's talk about the different realities that might happen. When you were preparing to be a clinician and going into a session, would you agree that thinking about going into a session is very different from having to restrain someone? I can remember early on in my own career working in an inpatient setting where we spent a great deal of our training on how to restrain people so that they wouldn't be physically damaged by the restraint and we would not be harmed in the process of restraining them. I don't know that this is taught today. When I've asked other individuals that work in psych units and inpatient settings, quite often they say, we just call for security. And then if I talk to security, they say, well, we've never been trained on how to properly restrain a person. There's some things missing from our regular training when it comes to helping people have an experience where they don't harm themselves or others when they're being treated for risk to self or others. But I think you can see how thinking about going into a clinical session and then having to restrain somebody is different. Let's try another one. What about watching a movie about mental health issues? Isn't it difficult sometimes when you see that the writer of a movie has got the diagnosis completely wrong, but they use terminology that you know is incorrect? But compare that to being pinned down by a sniper who just was released from your care. I've worked in a lot of active shooting situations where I had to debrief people afterwards from 9/11 to other environments, Las Vegas and places like that. And I can tell you there were mental health people there who wondered, could this be a client of mine? They were anxious to know whether or not this individual might have been in their care because this person had described fantasies about going to a facility with a weapon and blowing people up and shooting people. I think it was the Secret Service a few years ago that published data going back to Columbine. And if you think again about Columbine, I think this will be clear to you. Most of the shootings, active shooting scenarios in America, I think the answer was somewhere north of 75%, begin and end as suicide. The collateral damage, the homicides that occur in between, occur as a leveraging behavior on the part of the shooter to create an outcome that is so unacceptable that then their ability to shoot themselves and die at the scene is part of the plan. And that's been true in an awful lot of these active shootings. Now, in interviews with individuals from many of these active shooting situations, they would often report that yes, they had thoughts that this individual might be at risk to take their own life, but certainly they never thought they might kill anyone else. Do you see how that completely erases from our vocabulary the actual criteria, risk to self or others? I believe that suicide and homicide live in a duplex in the brain. And then quite often, individuals in care for suicide may also be contemplating homicide. And yet, quite often, it's never asked. People are not asked, have you also had thoughts of homicide? Have you also thought of killing other people? Are there people in your life that you felt like you would rather see them dead? Lots of different ways to be very clear, no wiggle room in the question, and yet not asked, not answered, and not recorded. So I would say to you, being pinned down by a sniper is a very different environment than watching a movie about mental health. So these meanings mean something different. So let me talk about them one at a time. Thoughts of suicide is very different than suicide behavior. But we often overlook this concept, and we use words like they are suicidal. Now, I can tell you that there's not a lot of agreement on suicidal. Jumping off a bridge. Jumping off a bridge is very different than thoughts of suicide because it's action. It's an attempt is what it is, often leading to death. So let me talk to you about one particular bridge that gives us the best insight and research that was done now over 30 years ago. The Golden Gate Bridge in San Francisco is a privately owned bridge. It's owned by a trust, and the trust has a board of directors that make all decisions about it. People pay a toll to cross the bridge. The Golden Gate is actually the landmass that it connects both sides to. It's not the color of the bridge that gives it its name, it's its location geographically. The jump from that bridge is so high that it's a 4-second fall for the average person before they hit the water. That means that their velocity at impact would be the equivalent of jumping off our state capitol onto concrete. The chance of living is extremely rare and low. In more than 1,000 jumps to their death, 9 people survived it. They didn't survive it without a lot of physical damage, but they did survive. And in qualitative research done by Richard Seiden back then, he found there were only 3 things that they all had in common. Now, one was that as they fell from the bridge, they remained conscious. Now, that's important because then we know that what else they had to say isn't an artifact of a delusion, a dream state, or some unconscious mind. The second thing they reported was, as they fell toward the water, time seemed to slow down. Now, that's a physiological reality of adrenaline hitting your brain. If you've ever been in a car wreck, you know how in your memory you'll recall that everything went into slow motion just before you had impact. This is what gives some fighters an advantage because they can control the adrenaline and give themselves a split-second benefit of seeing their opponent throw a blow and that they can then move away from. And the greatest fighters all have this ability. So when they say time seemed to slow down, it actually confirms the fact that they must have been awake. And the third thing that they all had in common, and that they all reported, was as they jumped, they wanted to die. And as they fell, they wanted to live. Now, that's known as suicide ambivalence. Now, here's a Latin one again. Ambi meaning two, valence meaning plus and minus. And the plus in this case is wanting to live and the minus is wanting to die. So ambivalence is that thing where we have opposite thoughts competing. You've probably had those before over considering whether or not to order dessert. You probably had them in regard to a relationship, whether to go forward or leave the relationship. Ambivalence is not something we don't all deal with, but ambivalence is exhausting when one side is about living and the other side is about dying. The Golden Gate Bridge teaches us that ambivalence is the key to understanding suicide. This is also the key to understanding how you can do an assessment in an emergency room and realize that both people are correct, that there's a part of that person that wants to die and a part of that person that wants to live. What we really want to be able to do there in our vocabulary is talk to both individuals in that one body. To be able to say to that person, help me know more about why you want to die, because the dying side wants to be understood. And what is an amazing reality is quite often we might be the first person that ever lets that individual talk about their desire to die, about what dying will get for them. Quite often individuals that are ambivalent, given that opportunity, even will say, you know, I can't believe I'm thinking like this, because that's that living side coming back in that wants help. Now we're talking to the whole person and not just part of that individual's problem. Now, crisis theory, which has been around since post-World War II, is also an incredible foundation that if you don't have it in your vernacular and you don't have the vocabulary of crisis theory, you might want to come to the NSTC and get one of our coping in crisis workshops. Crisis theory teaches us that every crisis is self-defined. And so often we don't recognize that. We don't recognize that a 12-year-old whose heart is broken for the first time is in as much pain as they can possibly be, dealing with the future where that relationship, that object of affection will not be part of their life. And to say to them in a glib way that it's going to be okay or it's not that big a deal continues their sense of isolation and has them believe that nobody really understands how much they're hurting. And I think crisis theory is a roadmap that every therapist, every mental health practitioner ought to know like the back of their hand. It's that GPS that helps you know exactly where the person you're interviewing is in the crisis theory. And it's a whole lot better to know how far upstream they are from thoughts of suicide, or whether they're already in the river thinking about suicide. So crisis theory would be another long-term piece of information that if it's not in your vocabulary, I encourage you to get it. Glib reassurance is what most people get in crisis, or they get advice. Now, advice is seldom helpful in a crisis. What is very helpful in a crisis is listening. And yet, when I do a workshop and ask mental health people to talk about what they like about what one person did over another, they almost always select advice over listening. We forget that listening, especially active listening, which is a skill set you can learn, is a powerful intervention for an individual who's struggling. It is a blessing when we have people listen to what we're thinking about and what we say. Growing up in Baton Rouge so many years ago, I recall that almost every house had rocking chairs on the front porch. And we used to do a really strange behavior, especially on the weekend. We'd sit in those rocking chairs and talk to each other. We'd also listen to what others had to say. I see that still go on in other countries when I travel to those. But here, especially in Baton Rouge, what I see are chained up chairs. Maybe a bunch of chain and a lock so that somebody won't steal those chairs off the front porch. I think we've got to return to a place where when COVID releases and gives us a chance to socialize more physically, we just still use our ears and listen more. Listening is a powerful intervention. And if you take nothing else from today, I hope you take that and maybe one other thing along. So let's see, my slide's not advancing, so let me see if I can do it a different way. I don't know what's going on here. Bill Gates, I know everybody likes Bill Gates, but whenever I use his equipment, there's always something going on. So here we go. Suicidology has some of these issues as well. So again, suicidology, study of suicide. The word suicidal, I can assure you that around the globe, in Baton Rouge, and anywhere you go, no one can agree what this word means. You tell me, what does it mean? Does it mean they're having thoughts only? Does it mean they've actually started to take their life? Does it mean they have a death plan for a year from now on an anniversary? We don't know what this means. It basically means there's something about suicide going on, but I can tell you this is used commonly to introduce a person to an emergency room by a medical person, by a police officer, by other individuals who say he's suicidal, she's suicidal. What I would tell you is it'd be much better if we could say something much more exact, like the client has been expressing thoughts of suicide to family members for the last week. That would be a much more exact way to describe the reason they're before you. But to say they're suicidal, it really has very little meaning to me. Thoughts of suicide, very different than behavior, wouldn't you agree? Now, suicide just means self-murder. So let's use the word murder for a second. I bet we can all conjugate this word the way it is on the slide. Murder, murdered, murdering. So if you look at that slide again and see those words spelled out, their spell check will not, Bill Gates will not come in and change that word when you type it in any of those letters. You can add it that way. Now, we know the difference between the word murder, murdering, and murdered. We don't have to add a word in front of it. Now, imagine what this might mean. Suicide, suiciding, suicided. Do you see how these three words, also like murder, convey an idea? Suicide is an idea. It's a cause of death on a manner of death on a death certificate. There are 5 manners of death on a death certificate, suicide being one, homicide being the other. Murder is actually a judicial term. But suicide, suiciding, and suicided give you a great deal of information about that individual's status. Self-murder would be the first one, having thoughts of suicide, having thoughts of taking their life. Suiciding means they're in the act. They're in the process of taking their life. It's very clear. And suicided would mean they have died. Do you see how different that would be than using this other word that we use all the time? Commit. If you could lose this from your vocabulary, I would be the happiest guy in Baton Rouge today, I do believe. This word is thousands of years in the making. It is no longer accurate. It is redundant. It has no use except to lay blame, create a sense of sanction, and create more stigma and taboo for family members who are left behind. Many people die by suicide, and it is not a conscious act. It's not an act where the word commit would even be appropriate. We have lots of different ways people die. We can just stick to the manner of death and say they died by suicide. But we could do this. Joe or Jane took their life. There's no wiggle room there. It's pretty accurate, and it's a lot less stigmatizing. You see, Joe or Jane died by suicide last night doesn't indicate that Joe or Jane was absolutely dedicated to hurting other people by doing a crime. And commit is often used only to commit homicide, which is a crime. Joe or Jane suicided while they were away. Joe or Jane killed himself while on leave. Military people see this a great deal when they have someone go away. Let me talk to you about the people most likely to come for help following a suicide of someone they care about. So we know that women are going to be highly represented. There's a paradox here about male-female. Men will die by suicide over 3 times as often as women. Women will attempt more than 3 times as often as men. It's a paradoxical approach. So when I ask graduate students in mental health, so who should we be worried about, men or women? Someone will usually answer correctly, which is both. We need to be worried about both. But our society tends to look at high number as the one to focus on. I would suggest that we've had it wrong for over 50 years. We should have been looking at the lowest numbers, because that means there's some protective features in that individual's culture that keeps them from dying by suicide. But what I know about women is this: women tend to reach out for help more often, and they build the bridges toward resources. Men tend to blow them up. So mother and sister and wife and daughter are going to come in on a frequency following suicide in the top 4. They're going to be the ones that walk through the door more often. When we get to number 5, though, we tie with son of the deceased and friend of the deceased. Now, in the military, this is especially accurate because a battle buddy is someone you feel closer to quite often than you would family members. What we know from David Brent's research in North Carolina more than 20 years ago is that the loss of a friend is the equivalent of the loss of a sibling. It's a very powerful connection that we have with our friends. They're the family we pick. When my best friend, when I was 12, went home one night and shot himself, I can assure you that his death rippled through our elementary school. He was one of the most popular kids in that 1 through 6th grade environment. We were all in 6th grade together. None of us could figure that out. And all these years later, if we have a high school reunion and some of us that are still alive were on that playground that day when we were told what he had done, we still ask that. Obviously, people look at me and say, why did he do that? And I say, I don't know anything more now than I did when I was 12. What I know is I miss him. So friendship, a non-familial relationship, comes through the door tied for 5th. It's important to recognize and not minimize that exposure, because they see themselves as disenfranchised grievers. They see themselves as not having a right to grieve the way they do. And I can assure you their risk is quite high in their grief. About 40% of all individuals coming for help following suicide report thoughts of suicide for themselves, which they never reported having had prior to exposure of someone they cared about dying. So friends should always be assessed. Then we see the father of the deceased, the brother of the deceased, the girlfriend, another disenfranchised griever, and who stepfather. Oh, well, Bill Gates is at it again. I see now I've lost something again. So as we reset, I guess, there we go. Thank you. Thank goodness there are people here that know how to do technology. I was president of the audio visually impaired school, and so I'm always grateful when people come to my rescue. So the cousin of the deceased and then the fiance are tied at the bottom there, the top 12 relationships. And then we squeeze them into the top 10. They represent about 80+% of those who will seek treatment. Now, a more recent research a few years ago showed that about 1/3 of all Americans have been significantly impacted by a death by suicide, which means that even though you have this sense of being all alone, probably your neighbor on the left or the right also has had a touch by suicide experience. What we know is people don't talk about it. They don't bring it out. This isn't something that comes out when the family tree is discussed. So the secrecy around suicide tends to continue to create a legacy in the future. So I want to give you a paradigm to consider that looks at how we might surround suicide with knowledge and vocabulary. So first of all, there's prevention. Now, all of us in mental health certainly appreciate the people that are out there doing prevention work, and I know many of you on the conference today are doing that work, and we should all buy you coffee and take you to lunch. Prevention work in suicide is probably the hardest, because every time a person dies, they become a statistical reality. But every time they live, having gotten help, they're a statistical non-event. So we have a difficult time showing that we are making a difference in this starfish category. This category of starfish work where you do one at a time, because suicide despite the high number, more than 50,000 a year. Suicide is the number 10 cause of death in America. Homicides around 16 or 17. COVID will realign all of this now. COVID being another disenfranchised grief that our society is going to have to cope with. But prevention work right now, and COVID, for example, are doing the minimum things that we're asked to do. Wear a mask, socially distance, wash our hands, etc. Now, prevention work in COVID has been challenging. It is in suicide as well. So we need to recognize that in our related fields, we're still fighting similar problems. Now, intervention means that a person is in the act of taking their life and someone interrupts that process. It could be that they've just gone to the car to start the vehicle and take their life through carbon monoxide, or they've just ingested medication, or they're sitting with a gun in their lap, or they have it pointed at their head. If we help that person not die at that moment, we've successfully done intervention. Inter meaning during, pre meaning before. Now, my contribution to the literature is a term called post, with a hyphen for Bill Gates, intervention. You'll notice that anytime you type the word postvention, spell check wants to hyphenate it when it's no more hyphenated than intervention. But post-intervention would be for someone who had attempted suicide. And whether they lived accidentally or whether they got help and came out of a treatment facility, if they get help in the future, that's post-intervention. And Suicide to Hope, or S2 Hope, is one of the programs for clinicians. CAMS is another program. These are all ways to help clinicians keep that person safe in the future from thoughts of suicide. A best predictor of a death by suicide is past attempt. So anytime we help a person having survived an attempt, we are helping them be prevention as well, preventing their suicide in the future. So post-intervention is another category. And what I like about this attempt on my part to separate those who have attempted is that it no longer loops them in with postvention. Post meaning after. Postvention in this case would be focused on those 12 relationships that I outlined for you a minute ago. Now, it's certainly true that those who come in following a suicide for help in their grief may also have attempted in the past or may attempt in the future. But postvention in this case is about people who are bereaved by suicide, which is the most common term used in the rest of the world. In America, anytime someone dies, you'll read in the obituary that so-and-so died and was survived by. And that's where the term survivor, when it comes to grief, is used. But now, when a person is successful in their treatment for cancer, they become a cancer survivor. So you see how the confusion for the word survivor has created lots of individuals that don't understand the vocabulary. So if you say to somebody, well, I'm a survivor of suicide, it means somebody you love died. Somebody died by suicide and it impacted you. But most individuals, if asked, what does survivor of suicide mean, they will think it's a person who attempted and didn't die. So you see, we already have this Tower of Babel that we have to struggle our way through to be clear about what terms mean. Now imagine how exhausting it would be for a mother to say, I'm a survivor of my son's suicide, and then have to explain that to somebody. Well, you mean he didn't die, but now you're having to help him? Or you see how confusing that would be? If we all knew that a survivor of suicide is someone bereaved, someone who's had someone die by suicide, someone who has suicided in their life, then we could be more clear right off the bat. So I've said to you that suicide is a paradox, and I open with the idea of understanding that opposites are true, and that the first one is that live or die. So I'd hope that you can use that word in the future. Explain to people when you say paradox that you're talking about opposites. This is why, unfortunately, most of the things you've been given on sheets of paper as myths about suicide only tell one side of the story. For example, most individuals, most mental health people, if asked, say, well, you know, a lot of people with depression have thoughts of suicide. Well, that's not true. 90% of people with clinical depression don't have thoughts of suicide and never will die by suicide. What we know is about the body count for those who die by suicide, looking in a rearview mirror, trying to do something called psychological autopsy, we've highly associated that many of the people that died by suicide were in fact depressed. Wow. Guess what? If we go out as a thanatologist, which I'm also certified as, another Latin word, thanatos was the Greek god of death, so thanatology is the study of death and dying. The person that you would know most associated with that field, other than Ed Schneidman that coined suicidology, would be Elizabeth Kubler-Ross. So many of us in thanatology recognize that giving away possessions being associated with suicide is extremely naive and narrow-minded. That research was done where they asked people who lost someone to suicide, in the last year, did your loved one do any of the following? And they had a large checklist, and one of those was giving away possessions. Well, I can tell you as a person now who's in the chronologically gifted stage of life, we give away possessions all the time without thoughts of suicide. Anytime you move from one house to another, you give away stuff. It doesn't mean you're thinking about suicide, but it could be an invitation that you explore. If someone gives you something, especially something that you see as quite valuable, you might ask them, this seems like an unusual gift for you to give at this time. Have you been having thoughts of suicide? Because I understand sometimes people have thoughts of suicide when they give away possessions. It's just an invitation to explore. And guess what you do when you explore that invitation? You listen. And as my 6th grade teacher used to say, you got 2 ears and 1 mouth. That's a ratio you should be using. Let's look at another one. Most suicides are the result of a multifactorial reality for the deceased. It's self-defined. And the fact that this person feels that this individual problem is a big problem, that's for them to decide. They have 100% decision about how big a problem that is. If we see it as a small problem, it's only because we're not wearing their shoes. And what's a problem when you're a teenager may not be a problem when you're a senior citizen. I like the term senior or older much better than the CDC's use of anybody over 65 being considered elderly. My father died when he was 97, and a few weeks before he died, I remember going by his home, and there was a fresh hot meal sitting on the table in the kitchen. I said, looks like somebody dropped off a meal for you. And he said, yeah, that old lady down the street drove by and dropped it off. And I thought, how old must she be? If he's 97 and he's calling her an old lady. So I think it is self-defined, folks. If you're 97 and you're still riding your horse, you probably don't see yourself as elderly. You might see other people as elderly, but you may not see yourself that way. We have to recognize that individuals see themselves through their own looking glass, their own mirror. Now, some words are more helpful than others, and some have less stigma and produce less shame for the family. So I hope you'll consider some of those. Now, Thomas Joyner has a theory about suicide that goes like this, that the 3 things that help us most predict an attempt, not a death, but an attempt, is a sense of thwartedness, where they don't see themselves as belonging, a sense of being a burden, and the last one, which is probably the hardest to get, is capability. Many people have a very hard time in the end being able to actually act on their thoughts of suicide. And all they're showing in this slide is that that darker blue area where they all coalesce increases our ability to predict an attempt. Most research today and all the large analysis that's been done is that mental health professionals have about the same skill set at predicting an attempt as a flip of a coin. It's pretty much just a flip of the coin. The best answers we have today is asking the person who might die what their thoughts today are about living. And I hope you'll remember that. Now, there's 4 ways for us to quickly consider suicide. So I'm going to put them all up here at once. First is to use the psychological idea that people who think about suicide, from the coroner's perspective, if they think about suicide and they die, the coroner is only interested in the outcome of the thoughts. For a psychologist, they want to know the intent. So we have 2 different sides to this scale: intent and whether or not they die or not. So if someone's intent is to die and they live, that's an attempt. If their intent is to die and they die, that's suicide. If their intent is to live and they die, is a category we don't have in the available to us on a cause of death, which is accidental suicide. And quite a few people end up in this category, because if you go to the other side where the intent is to live and they live, that's a term that has dropped out of the vernacular, but it's a really great Latin term, para meaning like suicide. This is an individual who's a manipulator. This is a person who uses suicide to control other individuals. This is a person with probably a personality disorder, and this is a person that's probably upset everybody in your clinical practice before you ever see them. They are very, very difficult to treat. And quite often they misjudge when the person's family member or friend will be there to rescue them, and they end up in that accidental suicide column. What I can tell you is the most at-risk person who doesn't die is parasuicide, to die in the future. 40 times more at risk to eventually die because they burn out all the bridges and resources of people who have time and time again tried to help them get help, and then they end up in the system and become frequent flyers. And eventually, either through escalation of method or lack of treatment, they end up dying, whether it's a deliberate suicide or whether it's accidental. But I would like you to keep that idea of parasuicide in mind, because they're high risk, even though they're very difficult to treat. So what can you do? Well, you can practice your vocabulary, and at the least, omit the word commit. So omit, commit. It's a nice little rhyme. You can make a rap with it, I'm sure. But the point here is, if you just start being aware of how often you say it, you'll stop saying it. So commit to omit, commit. That's what I'm hoping. Another thing you can do is you can think someone is having thoughts of suicide, then you ask clearly and directly. The thing you don't say is, are you thinking of hurting yourself? That, I believe they can pass a lie detector test on, because they really don't see it as hurting, they see it as helping. Suicide has become a solution. It is a form of maladaptive coping. So it's like getting drunk or taking drugs. They see it as some temporary relief from the pain they want out of. So you have to be very clear and direct with anything you ask of a person. So an example might be, John, I'm worried about you. Are you having thoughts of suicide? Are you having thoughts of killing yourself? These are terms, and then you stay with them, you listen, and you get more help. And for those of you that think that it's a violation of HIPAA or any kind of practice to go for help when a person says they want to die, it is not. That has been stated years ago after HIPAA came out. And remember, it stands for the Health Portability Act. It was intended to go with the client. We've created a line in the pharmacy that you don't stand in front of until it's your turn. And that way, supposedly, nobody can tell us how to apply a cream or something that they've been issued in a prescription. That's not what HIPAA was intended to do. And when a person's at risk to self or others, I tell my clients, I'd be happy to stop a school bus and get help if that's what I need, because you staying alive right now is more important to me. I'll deal with any challenge to my ethical status, because the reality is no court is going to challenge that. That would be seen as frivolous. Now, let's see. I think, well, my slide didn't advance. So here's the next thing I want to say. Self-care. The best information you get every time you get on a plane is first put the mask on yourself before attempting to help others. So we know that if we're trying to help people and we're doing this mental health world, let me remind you of this statistic. Mental health professionals have very high rates of suicide. And when asked, who would you talk to? Mental health people routinely say, if I were having thoughts of suicide, I'd speak to a family member or a friend. See, we wouldn't go to another mental health person. So we've got to make sure that we're taking care of ourselves if we're going to be helping other people. So I've got this very simple assessment for you to take. One is, if you've ever been on a four-legged stool and one leg was shorter than the others, I think that's truly why sugar is put in a packet, so we can push it under the chair to try and keep them rocking all the time. But the reality is, you want all four legs evenly put on the floor in this model. So if one leg's shorter than the others, you got to work on making that leg longer. It's not about sawing off the other three legs. Participation in a supportive community. Look how challenging that is to us right now. We may socially distance, but we don't have to be emotionally distanced. And a supportive community, in my definition, is a community that checks on you, asks you how you're doing, and doesn't give you any wiggle room. If you usually go to a certain activity and you quit coming, they check on you. They don't have their chairs chained up on the front porch, and they sit and talk and listen. Physical well-being, especially challenging these last 7 months, but not impossible. You just have to rise to the challenge. Even if it's just getting out and walking, find a way to do that so that you're safe and it keeps your physical well-being up and running. Now, control over daily activities has been especially challenging during COVID. And so being able to get up, get dressed, and go about your day could easily drop out of the front windshield. But I encourage you to realize that transitions in life, for example, retirement, or where people struggle sometimes to keep up those daily activities. And the last is the first leg of the stool to go in a crisis, doing the things that give our life meaning, make us productive and creative. So take that simple test for yourself. Consider checking into trainings that we have available. We're starting to do trainings for trainers on small groups right now in our center starting next week with 9 people at a time so that we can socially distance and follow COVID restrictions. But we can't wait any longer to help people become more suicide aware. And you today have taken a chance to do that. I thank you for coming. I think we may have some questions. Robin, as moderator, do you have any that we can throw out? Assist, I know, can't be taught during COVID because of the learning restrictions. It's an 85% experiential workshop. So if you don't have other people there to practice the skill set you're learning, you won't be able to provide the service that you're training to do. So Assist may not, but there are certainly other ones. CAMS for clinicians, CAMS is now doing virtual training. And you can contact the NSTC and go to our website and see what trainings we're going to have. We just were awarded a SAMHSA grant to do some training statewide. So if people are interested and they live in a different part of the state, no matter where you live, email me and let me know you'd like to attend a training. And when we come to your area, your region, there are 10 LGEs, I think is the acronym they use. These are limited government entities that used to be known as the mental health department, you know, in your community. So we'll be doing trainings throughout the state with a one-day training that will provide assessment skills and virtual learning prior to that.
And well, since September is Suicide Prevention Month, so if someone interested in showing their support for suicide, are there any activities that are available this month, or what type of things could that person do to learn more about suicide?
Absolutely. September is Suicide Awareness Month, but again, it's much like food banks during Christmas. People are hungry year-round, and we need to know that people are at risk year-round. But September is where we sharpen the pencil and really look deeper into this cause of death. The American Foundation for Suicide Prevention, which is known by the acronym AFSP, is doing walks and other publicly held observations around the country. So you could go to their website or just Google AFSP or Suicide Walk. All of these things often are being done year-round, but September especially. The American Association of Suicidology, and believe me, if you can spell it, you can be a past president also, just like I am. You can go to the word suicidology.org, and that's where you can get downloads of suicide data, but also information about trainings, and they're doing free conferences this month for that particular organization, and mental health conferences. The great advantage of virtual is that a lot of things are being offered virtually right now. It is a lower cost environment. I'm so grateful that Women's Health Foundation is putting on this conference.
And there's another question. Who do I speak to when I'm having difficulties? How can I reach out or connect to somebody?
It's a great question. I really appreciate that. The crisis lines in America are a great resource. And in the next year or so, we'll have a 3-digit dial-up that'll be 988, I believe. And that will allow you to connect for mental health help or suicide. But in the meantime, 1-800-273-TALK, I think it's 8255, is the national helpline or lifeline. The National Lifeline offers both text and verbal response, and I would recommend that you do that. We want people to call us when they're not at risk. We want to talk to people in crisis before they're in the river of suicide. So the further upstream, the better. And mental health professionals, you can be anonymous. There's also clinical support for a client. When you have a client die by suicide, we have clinicians, suicide survivor groups that meet online. So there's a lot of resources through the National Lifeline and also through the American Association of Suicidology and American Foundation for Suicide Prevention. But SAMHSA is funding some trainings throughout the state this month and for the next 16 months. So contact your local mental health association also. The one here in Baton Rouge is the recipient of the grant that we're working with the Office of Behavioral Health with. Got a few more minutes before I'm out the door, so if there's any other questions that anybody has.
Or Dr. Campbell, are there any trends or patterns that you're seeing with people now, especially during COVID, patterns in terms of what type of concerns people are expressing right now?
Well, I appreciate that question. I absolutely are seeing more desperation. I think we're going to see a desperation death is what I would say. We're going to see people that have not been able to continue to wait for safe harbor. They just are tired, exhausted mentally and physically and emotionally of waiting for COVID to be over with. They're frustrated with the continuing second waves and third waves and spikes because people will gather and not provide safety for the participants and continue to spread this. So what I'm seeing, especially in the individuals I speak to, is an ongoing sense of hopelessness that a pandemic can create. Most of us have never lived through a pandemic, so we have no idea. But today, with our technology, we can know how bad it is all over the world and become very hopeless. So I think being able to break yourself away from some of the more negative information can stop that cycle in your mind where you begin to say, at first I was hopeful, but now I'm hopeless. The more you have that sense of hopelessness, the more likely you are then to stop doing the safety things that you've been doing that's kept you alive so far, free of this illness. For those who have contracted COVID and have recovered, they may have a sense of invulnerability that might be false. They would want to be very mindful of continuing to do the things that might have kept them safe in the first place. Now that they've had it, we don't have clear knowledge that they will be immune in the future, and the virus seems to be continuing to change and transform, and we're going into flu season. where symptoms will be confusing and we won't know whether a person has a cold, the flu, or COVID. So I'm afraid we're going into a less knowledgeable area right now, time-wise, but the temporal distribution, the time distribution, to me is what's difficult. Crisis theory is defined as something that resolves itself in 6 to 8 weeks, one way or the other. We're well past 6 to 8 weeks. So we have to find a way to dig down. And the best references we have are long-term combat, where an entire country in World War II did everything they took to support the troops for years, which included sacrifice on every individual in the country. We need to do sacrificial behavior today to ensure that we'll emerge from COVID healthy, safe, and wise. Any other questions? I'm glad Robin has that job and not me.
Are there any populations during COVID or in general that might be at risk or maybe at higher risk right now for suicide?
Well, you know, there's a parallel here between what we've learned about COVID risk factors, which have been pre-existing conditions and age and exposure, and suicide. What we know is that suicide affects the entire age range, all cultures, all races, all everything, but yet there are certainly some that have more bodies than others. But if we drop away that idea of men dying more often and women attempting more often and saying we need to look at one over the other, we'll have a better answer to COVID as well as a better answer to suicide. All of us are at risk for both. What I do think we're going to see is the more desperate a person's thinking is, the more stinking their thinking becomes. And the more you're convinced you have COVID, the more hopeless you're going to be. The less likely you are to go for help or to be tested. We've seen this with other problems in our society historically, other causes of death that rose up as a result of exposure. The most common one I would say would be HIV, and people were diagnosed with AIDS. And yet today we have more hope for people that have that happen in their life because there are treatments that are available. That will happen with COVID. It can happen with suicide. But right now we don't talk about either in an informed way because we're on a learning curve with COVID. And unfortunately, we're still on a learning curve with suicide. I'm hoping we can shorten that curve as well. Suicide is not a forever state of mind, and it is not brain surgery. It may occur in the mind, but it's not brain surgery. And I'd like to tell you one saying that really meant a lot to me when Ed Schneidman taught me this. Schneidman says the mind is more than the brain. Because when you think about it, our mind is our memory of all our life events. Our mind controls our value system. It controls those things we aspire to do and the things we work not to do. Our mind is more than our brain. So COVID is more than just our brain or our body. COVID is also a mindset. And the mindset we need right now is much like the mindset we need for suicide. Learn, information, and education is the smartest thing we can do. But all populations are at risk for both. That's my best answer to that, and all cultures.
Well, I think that's all the questions we have.
Okay.
Some people are asking for your email address again. Would you?
If they go to the website, the shortest website is BRCIC, Baton Rouge Crisis Intervention Center.org. Look under you'll see a logo for the NSTC. And my email is on there, and you can email me. It'll have my name and my email address. I'm pretty sure it's fcampbell@brcic.org, but I have several emails, and I get them confused sometimes. So remember, I'm old, so I don't always get it right. Love to get your emails, though. And for all those who have served our country, as veteran myself, thank you. I know that freedom isn't free. I met with 377th on Monday virtually, and we had a couple of hundred military families on there and friends, and veterans. And we continue to see, as we will this weekend at a TAPS conference, so many families gravely affected by the price of freedom, and especially suicide is our #1 cause of death in military branches. So thank you for being here. Thank the foundation for providing this format. I think you go to a break.